Hello everyone, welcome to the Echo course at CEC. Today I will talk about infective endocarditis, a step-by-step approach. First of all, infective endocarditis is an uncommon disease, up to 10 cases per 100,000 population per year. But the mortality is high at 20%, and about 40% of those patients with infective endocarditis will need cardiac surgery. The diagnosis is aided by the modified Duke criteria, which include vegetation, local complication, or valve destruction on the echocardiography as a major criteria. So our talk today will target the echocardiography as one of the diagnostic tests to patients with infective endocarditis or suspected infective endocarditis. First, we should have a stepwise approach for infective endocarditis. The first thing we ask about is if there is a vegetation. Then, is there a local complication? Then, is there a valve destruction? Then, check the other valves. Finally, we do 3 steps: assess the grade of regurgitation, assess the left ventricular function, and detect any predisposing abnormality. So the first question is if there is a vegetation or not. What is a vegetation? Vegetation is typically a mass attached to the valve and moving with a different phase to the leaflet, and it may sometimes be integral to the leaflet. It may be difficult to differentiate from other types of masses like calcific or myomatous degeneration, fibrin strands, or flail chordae. This is a particular problem if echocardiography has been requested with a low clinical likelihood of infective endocarditis. So the first comment, if you find a mass that is maybe considered a vegetation, to note the size and mobility of the vegetation, because highly mobile masses larger than 10 millimeters in length have a relatively high risk of embolization and may affect the decision for surgery. Then vegetations usually occur on valves, but you must consider the other sites that you may find the vegetation there, like the jet lesions or around the orifices of a VSD or ASD. Then what should I write? So there are some suggested terms for describing a mass. First of all, you can write this mass is atypical of a vegetation, or consistent with a vegetation, or consistent but not diagnostic of a vegetation, or consistent with a vegetation that looks more like calcific degeneration, or finally, most with calcific degeneration. Here as an example, we can find this mass attached to one of the tricuspid valve leaflets, highly mobile and moving in a different phase of the valve. The valve, when the valve is going out, it delays. When the valve is going in, it delays also. Another example here, where can we find the vegetation? Yes, small party here and another small party here. And if we do a zoom, you can find this mass. So as I told you, the jet may cause implantation of a vegetation in non-valvular sites. Here we can find a mass, a large, huge mass that is attached to the Eustachian valve. Here we can find the 2 firm masses, not highly mobile, attached to the tips of the leaflets of the mitral valve, and they are called the kissing vegetations, causing severe regurgitation, as you can see. In another example, here, when we opened the aortic valve, we can see this vegetation and this causing some affection of the cusp of the aortic valve. Here we can find the cavity. This cavity is at the attachment of the prosthetic valve, and this cavity is abnormal. Here we can see native valve with two vegetations, very large in this apical 5-chamber view. And here when we change it to the parasternal long axis view, we can see one cusp is destructed, one cusp has a vegetation, and the other large highly mobile veget is attached to the LVOT. Here is another example of the tricuspid valve where there is a vegetation that is attached not to the tip of the leaflet, but to the middle part and base of it. This is causing just mild to moderate regurgitation of the tricuspid valve. Here another attachment of a vegetation that is also attached to another part of the valve, not the tip of the leaflet, but on the middle part to the base of the leaflet of the mitral valve. Then the second question is there a local complication? Where a new paraprosthetic leak is a reliable sign of prosthetic endocarditis provided there is a baseline postoperative study showing no leak, and an abscess usually suggests that the surgery will be necessary. Transthoracic echo is good for showing anterior root abscesses, while transesophageal echo is better for posterior root abscesses. Here we can see a prosthetic valve at the aortic position, and this prosthetic valve is moving freely where there is just one thread attaching the valve to the site of implantation. And on color, we can see this severe paravalvular regurgitation. The next question is valve destruction. Valve destruction may show as disruption of the leaflet tissue with unusual patterns of movements like dog legs or small flaring signals, valve perforation, new prolapse, or new or worsening regurgitation. As we can see in this example, this tricuspid valve leaflet is totally destructed, as you can see, eaten up by the vegetations and the infection. Then we must check the other valves, because multiple valve involvement is particularly likely with invasive organisms like Staphylococcus aureus, and the jet of the aortic regurgitation, as we have seen in one of the previous examples, may impinge on the anteromitral leaflet to see the vegetation or cause local infection leading to an aneurysm or perforation. Then assess the grade of the regurgitation. This is for regurgitation from any cause. The color jet and spectral Doppler may be difficult to interpret because of artifact caused by the vibration of a vegetation, ruptured chordae, or torn leaflet. A hyperdynamic left ventricle is a clue to severity, and the presence of severe regurgitation informs the timing of surgery, especially if there is LV dysfunction. Here, in this example, we can see this comb artifact, where the vibration of the vegetations cause this overestimation of the regurgitation. The next step is to assess the left ventricular function. Progressive systolic dilatation of the left ventricle aids the decision for surgery, and if there is acute severe aortic regurgitation, look for a transmitral E deceleration time less than 150 milliseconds on pulsed Doppler. This is a sign of a raised left ventricular end-systolic pressure and an indication for urgent surgery for sure. Then, next step is to detect any predisposing abnormality, because about 1/2 of cases develop on previously normal valves, but the predisposing abnormalities must be searched. Nowadays, there is a lot of pacemakers and implantable defibrillators implanted, so endocarditis is increasingly common. Some examples of the predisposing abnormalities like native heart valve disease, prosthetic heart valves, prior endocarditis, congenital diseases other than ASD, hypertrophic cardiomyopathy, and for sure implantable pacemaker or defibrillators. Then we ask ourselves a question: is transthoracic echo normal despite suspicion? Is there a need for transesophageal echo? Yes. If the clinical likelihood is low or an alternative diagnosis emerges, echocardiography is not indicated. While if the clinical likelihood is moderate or high, choices include immediate transesophageal echo or a further transthoracic echo plus or minus transesophageal echo after 7 to 10 days. We must keep highest level of suspicion in specific individuals, like patients with prosthetic heart valves, intracardiac devices, when we suspect abscess, and in patients with a history of IV drug abuse. Finally, we should talk about some pitfalls. First, echocardiography should not be used as part of a fever screen, since it then has a very low yield and risks detecting innocent bystander abnormalities, reporting innocent bystander findings as vegetations, and this will lead to overdiagnosis of infective endocarditis. Second, missing progressive valve regurgitation as a sign of endocarditis, because if you have a certain degree of regurgitation at day 0, and after 7 days this degree of regurgitation is increased, this means that there is infective endocarditis. Lastly, overusing transesophageal echo when it will not change the management, especially if surgery is already decided, like in cases of right-sided infective endocarditis and device-related infective endocarditis. Thank you so much, and see you in another session.